Hello, I'm Bernadette Bartlam. I'm a senior lecturer in health services research, and I'm here to talk today to Dana Rosenfeld, who's a reader in sociology at Keele University, about her work around HIV and aging in later life.
Hello, Bernadette. Hi. I think you also forgot to mention that you are a gerontologist yourself, and that you are on the British Society of Gerontology Executive Committee, and we are here at the British Society of Gerontology Annual Conference. Other than that, you did fine.
This interview is going to go really well. So, Donna, tell me about how you came to be working in the area of HIV and aging.
HIV and aging. Well, I'm an accidental gerontologist, as many people are, and I started researching aging during my PhD thesis when I was looking at older lesbian and gay men, age 65 and above, in Los Angeles. And I got very into that research, and it produced a book, and it produced a number of things. And one of my main finding was that the older gay men and women who came out, who identified as gay before 1969, before gay liberation, adopted a very different understanding of what homosexuality was. It was a stigmatized condition, they should remain in the closet, there was a whole range of practices around that ideology. Whereas those who identified as gay after 1969 did so through the discourse of gay liberation, which produced a very different understanding of how to do being gay. And there the research sat. And then around probably 6, 7, 8 years ago, I was at Keele University giving a lecture to students who were taking a master's in gerontology and geriatric medicine about my research on lesbian and gay aging. And it occurred to me that the next generation of older gay people, because the ones that I had interviewed for my PhD thesis were born before 1930, but the baby boomer generation of older gay men would not have had Stonewall or gay liberation as the dividing point between two ways of being. It would have been the AIDS epidemic, which I encountered when I just got out of university, so I saw it, although I wasn't as politically active as I should have been. So that led me to think that the future of lesbian and gay aging was, in fact, so riven by HIV that it would be irresponsible to talk about gay aging without bringing the AIDS epidemic in, because that was the World War II, that was the watershed for the gay community. So I got a small grant from the British Academy, whom I thank, to look at the current social worlds of older gay men who had lost people to the AIDS epidemic in the 80s and 90s. And that led to a larger grant proposal, which was submitted to the MRC ESRC, which was thankfully funded, on HIV in later life. And that's the major body of work that I'm publishing off of now. That study ended in 2011 to 2013, but that's the material that I was presenting here today.
Right. And so what are the key messages from that work? From
that study? Well, a lot of the research into aging with HIV, which has really only begun to get some power to it around 8 or 10 years ago, it's gaining ground now, has much of the research has claimed, the early research has claimed that the social support networks, particularly of gay men aging with HIV, because they lost so many people to the AIDS epidemic and are now aging, many of them, particularly the long-term survivors, are aging in a context of social networks that were vastly depleted, that their social support networks are fragile. And we didn't find that it was quite that simple, and we didn't find that the distinction between formal and informal networks really worked in the context of our participants. Let me just back up and tell you who our participants were. We gathered a purposive sample of older people living with HIV in the UK, primarily England. Most of them were, all the ones we interviewed were in London. We collected 76 life history interviews, 100 mental health surveys with older people living with HIV. We conducted focus groups with them as well, and we had stakeholder interviews. Now, the three largest groups of older people living with HIV in the UK are MSM, men who have sex with men who are white, Black African heterosexual men and women, and then white heterosexual men and women. The vast majority of those are white gay men, but then those other two groups in that order. They have very different histories with HIV. Obviously, the gay male community's got a long history with HIV/AIDS, high prevalence rate. None of the older gay men whom we interviewed didn't know anybody living with HIV before they were diagnosed. So they were diagnosed into a community setting in which it was familiar. Doesn't mean it wasn't shocking and distressing, physically and mentally, but it wasn't an unfamiliar territory to them. The Black African heterosexual men and women, all of whom were migrants, so they had very different family situations. Most of them had biological families still in their countries of origin. And of course, their migration status was very, very tenuous, so there were issues with that as well. Obviously high prevalence rates of HIV and AIDS within their home communities and within the Black African community in the UK, but there's a particularly pronounced stigma about HIV within the Black African community. So that it really restrained any conversation. So they may be sitting next to somebody living with HIV in their church, but they don't necessarily know that they're living with HIV. The white heterosexuals, no history of HIV within their communities that they know of. None of them had known anyone living with HIV before they were diagnosed. And for them, they were completely reliant on HIV organizations and websites to actually connect with people. So most of our participants, half of whom were parents, by the way. I mean, virtually all of the heterosexuals were parents, and a fair proportion of the gay men were as well, having been heterosexually married beforehand. Most of them actually had supportive people within their networks who were not living with HIV, family, friends, etc. But that sort of support wasn't all that they needed. It was practical support, it was emotional support, but it was support by people who didn't know what it was like to live with HIV, other than on a second-hand basis. And they were telling us over and over and over again, you need to be in the same boat. It's one thing to sympathize, it's another thing to empathize. And the term in the same boat came up over and over and over again. So that was one finding, how incredibly important it was to be connecting with people who have what we call experiential knowledge rather than just informational knowledge. And access to the people who are living with HIV differed across the groups. Of course, the gay men had one and the other. So the social support scenario is more complex than we would have thought, yes.
Can I just ask you about the impact of stigma? You mentioned in Black heterosexual people the lack of being able to communicate within their own social group.
Yeah.
How did that translate? Was it in terms of support?
Right. Well, the Black African community was class is always an issue. Black African community was heavily reliant on benefits.
Right.
And for those who relied on benefits, they were even more likely to access HIV organizations, go to the support groups, go there, hang out, right? And for them, the HIV organizations were the primary source of connecting with other people living with HIV. One of our informants said, one of our participants said, you can't just walk up to somebody on the street you don't know. Because of course with the medications, right? If you're on appropriate treatment, it's controllable, and you no longer have the external insignia of the opportunistic infections that would beset people before those. So you can't actually tell. So they would meet people in clinics, right? Which also is complex because they're not necessarily HIV clinics. They could be STI-GUM clinics, so people could be there for other things. So a heavy reliance on HIV organizations for them, and the white heterosexuals as well. Then they met people that maybe they were friends with outside. Maybe they would go to the movies with them. And of course, dating was an issue. A lot of people were looking for romantic connections because living with HIV as an older person makes romantic connections, makes dating even more complicated. So that was one main finding, was the complexity and the subtlety of the social support circumstances. Another one was, pardon me, that there's just a high degree of uncertainty. This is the first generation of age with HIV. In the history of the human race and in the history of the HIV/AIDS epidemic, this is the first generation ever. These people have never existed on the human planet before in any real numbers. Unless things change within the next 10 or 15 years, people over the age of 50 are going to comprise the largest age group within the HIV sector. Certainly in resource-rich countries where you have effective medications. These effective medications, which were introduced in 1996, are permitting people to live with HIV into later life and probably even achieve near normal life expectancy, not without costs. People living with HIV have got premature onset of comorbidities, multiple morbidities. Compared to their HIV negative peers, the comorbid scenario is much more dire. But they were, and again, we interviewed people 2011, 12. Things have become a little bit more clear since then, but just a high degree of uncertainty. One man said, I'm a guinea pig. I've been living this for so long. We don't know what the consequences are. Is this normal aging? Is it HIV? Is it aging? Is it the HIV medications if I feel this pain? What is going to happen at the intersection of HIV, long-term medication use, even short-term medication use, because a lot of these people were diagnosed in later life, and the quote-unquote normal aging process. So a high degree of uncertainty, and the clinical sector can't give them any answers. They're like, basically, you tell us. You're the ones who are experiencing this and are going through this. So that was another main finding, and it was very poignant to hear them talk about that, because it becomes very hard to plan for the future, and that also overlaps into the very, very difficult issue of disclosure. Our participants were saying stigma is the biggest issue, disclosure is the second biggest issue. Not knowing what the future is going to be is the third biggest issue for us.
Tell me more about disclosure.
Well, HIV remains highly, highly stigmatized. Education about HIV has had a very patchy history. You may remember in the 1980s in this country the tombstone ads. And there hasn't been a lot of advertising or public health messages or images about HIV in the last 10 or 15 years. It's just not out there. University campuses, I don't see it. And I've asked students about that, and they say there's chlamydia posters. There's nothing about HIV. So a lot of people who don't know they know people living with HIV still have got a very outdated picture of what HIV is in terms of it's highly infectious, which it's not. Certainly not now. It never was. It was communicable. It was never really infectious. They have an image of HIV as something transmitted between people who are doing something wrong, who are lacking self-restraint. Either it's irresponsible drug use, or it's irresponsible sexual activity, or it's immoral sexual activity. And that stigma is very, very enduring. So the issue of disclosing that you're living with HIV can be very, very tricky on the dating scene, in terms of intimates, in terms of family members, certainly work, issues like that. You simply don't know how people are going to react, because you don't know what they know. You don't know whether they are holding incorrect knowledge about HIV, whether they're biased about it, whether they've got homophobic beliefs, whether they assume that you're really a gay man if you're a straight man. All of those things. And even saying, hey, what do you know about HIV can itself be dangerous. So they use all sorts of techniques, and that's something else I presented about yesterday, to sort of figure out, to sort of divine how much somebody might know about HIV, and therefore whether to disclose to them, and if so, when. Don't forget, a good proportion of the study participants were parents. And disclosing to a peer, somebody who's 40, 50, 60 is one thing. Disclosing to a child is another thing. And this was absolutely fascinating, because if you've got 3 kids and one's 15, and they may be old enough to understand what you're talking about, old enough to not divulge it, to not disclose it on your behalf, not to gossip about it, but your second and third kids aren't. What do you actually do? With older parents, not so much of an issue for reasons I won't get into now. But the intergenerational issue of disclosing to your children, for whom they felt it was highly relevant, because at some point they were going to become poorly, at some point in anybody's life. And HIV is going to become relevant to that. Do you want to risk them feeling that you've hidden something from them, that you're lying to your children? That's one risk, is waiting too long, especially if a health crisis forces the issue. The other risk is that you disclose too soon, and they don't understand it, or they divulge it. They become upset, or you're waiting for the right time, but they find out from somebody else, or you wait until they've already encountered incorrect information about HIV and therefore have become biased, so that when you do tell. So timing is very tricky for this, and this is something I wasn't expecting when you think about older people living with HIV. But a lot of these people were in their 50s. So it's possible for somebody to have a 10-year-old child.
No, absolutely, and that complexity in terms of how you navigate those relationships as they themselves change over time.
Indeed.
I want to just ask you about the future.
Right.
So one of the things that's been occurring to me very strongly as you've been talking is the potential double jeopardy around ageism and aging with HIV.
Indeed.
And I know that the next piece of work that you're looking at specifically focuses on aging with HIV.
Yes.
And I wonder if you could just say just something about what you see as the major challenges in that.
Okay. Well, first of all, we did encounter a heavy concern, a heavy expectation that older people living with HIV would be doubly stigmatized, because, especially among the women, and of course the sample of women was very small. We only had around 20 women in the sample. It was even though we had 76, it was a proportional study. Especially among the women, the expectation that people would think that there's something particularly disgusting about somebody older having had sex, even if it were years beforehand, and that they would lose their status as the wise woman, as a woman of dignity, if people knew that she had a sexually transmittable disease, condition. I wasn't the first person who found that. Charles Emlet had found that earlier, but it was very, very much there. But the issue of stigma is absolutely massive, and that's, of course, sadly, across age groups. It doesn't dwindle in old age. It takes on its own flavor in later life. We are beginning to look at securing funding to look at HIV and long-term care, because particularly given this is an unexpected population, and the HIV sector is alive to the fact that we now that people are in their 50s and 60s and even 70s, they've got very complex care needs, and of course the social stigma layered onto it. So how can we secure appropriate long-term care for people, many of whom are quite impoverished because of interrupted careers, the Black African population, migration as well, with a lot of the long-term survivors, interrupted careers, they don't have pension plans, in and out of jobs, etc. Very reliant on disability benefits, so you've got a very distinctive financial picture. You've got an increasingly fragmented social care system. You've got HIV-related stigma, right? And you've got very complicated social networks, right? Particularly among the older gay population who've lost a lot of people, and very complicated comorbidities, which we're still beginning to understand. So we're looking at that,
So I guess this provides a really unique lens, actually, to look at inequalities and human rights in later life.
Absolutely.
A very, whilst at one level it's very specific, at another level the lessons that can be learned are potentially so transferable.
Absolutely, because
powerful.
What this particular older population does is it highlights and puts on record, it puts on very clearly on the table the centrality of comorbid conditions, an increasingly fragmented healthcare system, and social support resources in the community, which can be very diverse. And how do people actively try to make sense of that and navigate that? So it highlights those things.
So brilliant in going forward. So I hope to see you back at the BSG.
I think I'm hooked.
Thanks,
I think I'm hooked.
Donna.
Thank you so much
you.
for that. Thank you.